evolution.
I understand. Yeah.
Yeah. Yeah. Well, let me go ahead and introduce you so that others can benefit from your wisdom and that we can make sure that we're hearing all that you have to say. So thanks for joining, all of you who have tuned into this webinar. We're really honored today to be able to have Marc Lewis come and speak with us. I'll just say personally, again, I messaged Marc about this. I first got to know him when I was a graduate student at the University of Oregon, and he was one of the celebrated invitees that Jerry Patterson asked to come to Oregon Social Learning Center, where a number of us were doing our graduate kind of research. Jerry always had his eye out for people of the field and developing units that could help us understand the dynamics of human interaction in ways that helped us better understand trajectories towards disruptive behavior and ways that we could intervene. I was more than a little intimidated when Marc arrived because the methods that he was describing and presenting were so sophisticated that I could stay tuned into the content for the first 10 minutes and then just had to sort of follow along by my fingernails or whatever. But the work has continued to be really influential in terms of thinking about dynamic systems approaches and how state space kinds of analyses can help us in a much more sophisticated way understand the ways in which interactions occur and unfold through time. At the same time that Marc pursued that work, he also has had a really interesting career trajectory that has led him from the kind of basic science back to his sort of original roots of being trained as a clinical psychologist, and is now an addictions therapist as really his primary focus. So this is all highly relevant to the P50 Center grant at the University of Oregon that's funded by NIDA, because really the complexities of human interaction, especially in the parenting in the context of opioid misuse and addiction, is an incredibly complex kind of set of phenomena. And at the same time, at the end of the day, what we're really interested in is how do we help those who are face to face with these kinds of issues, either themselves or their parents or loved ones, really understand what the change process might entail. So I will not go on further because we want to maximize Marc's time, but I just again say that this is highly relevant, I think, to many of us who are doing this work, and we're really looking forward to hearing from you, Marc.
Thank you, Phil. You're very kind, and it's that work using dynamic systems, observational behavioral methods, that got kind of branched out to my wife and colleague Isabella Granick, who took it into looking at kids with various kinds of psychopathology, aggression or anxiety problems, and to Tom Hollenstein, who was soon became my grad student and then took the state space grid method forward and did a lot of stuff with it. Well, I kind of went out the side door and went from studying the brain, which, that's pretty simple, and to really eventually getting involved in using dense array EEG to look at patterns of cortical activation that corresponded with different phases of before and after treatment, for example, for kids with antisocial behavior problems, stuff like that. Anyway, you guys took it over. I continue to recede from it because I can't keep up with it. It's really difficult to adapt dynamic systems methods and the whole notions of self-organization and system dynamics to psychology, which depends on observational and other methods. That it's not physics and it's not easy. So I'm glad you guys are carrying on the work in one way or another. For me, I've gotten out of all that stuff really, and really focused on addiction, as you said. Kind of went back to it later in my career. And this talk is obviously an effort to put together some of what I understand about addiction as a psychologist and also as a neuroscientist. I'm now a retired neuroscientist, but I still think about the brain a lot. And still like to look at the connections between what we're learning in neuroscience and what's happening in the real world of people with addiction problems. How do we help them? Do they need help? What's going on? How do addictions develop? How do they emerge? How can they be treated? Should they be treated? Or should we be working on other aspects of change, changing societal issues that then drive people towards addictive use patterns? So those are some of the things that I'm interested in now. Also, I should front end it. I have done this for years in my talks by saying that I had a very serious drug addiction problem throughout my 20s. I used opiates and I used them a lot, and I used them in illegal ways, in all kinds of illegal ways, and really had to kind of quit that, clean up my act before I restarted graduate school and became a psychologist and a professor. So it happens all the time, by the way. You know, I'm no hero in that respect. In fact, I think something like 90% of people who are addicted to any substance will recover by the age of, was it 50, 55, something like that. People just end up stopping one way or another. Well, except for the 10% who don't. And for them, maybe we need to have more extreme or more human methods of connecting and helping. Okay, so yeah, changing currents. I'm looking at changing currents in how we think about addiction and putting brain and behavior together again. Well, because we've kind of taken them apart, and I'll show you what I mean by that. The predominant approach to understanding addiction in North America, Canada, the US, also in Europe, has been the disease model, the idea that addiction is a brain disease, which was very much hailed by NIDA, the National Institute on Drug Abuse, that Phil mentioned briefly as the host for the funder for his next position. So what about it? The idea, okay, addiction, a brain disease. Well, that's kind of interesting. That's better than saying that addiction is a moral flaw or, you know, self-serving character weakness, sinful, weak-willed, whatever it is, you know, the kind of way we used to think about it, maybe in the old days, or at least some people did. In the old days, people didn't think about it like that at all. If people wanted to use alcohol or other substances excessively, that was perfectly fine. But nowadays, addiction is defined in a very specific way, and we have to make sense of it. It doesn't really fit with other aspects of our social world. So along comes the brain disease model, especially in the 90s. Much of it funded research in looking at the neural mechanisms involved in addiction, funded by NIDA. And that did a lot of good, but it also did some harm, in my opinion, and that of others. And I want to show you quickly what I think is wrong with the brain disease model. The idea that brain change equals brain disease is just simply not rational in my view, because, well, because in a nutshell, brains are supposed to change. That's what they're supposed to do. They change because, unlike livers and lungs and hearts, their job is to change, to continue to adapt. Their plasticity and flexibility is a fundamental feature of their how we use them and how they work. So no, brain change is not a problem. Let's understand the kind of brain change involved. And I don't know if you can see. I don't know if okay, let's try that. I want to make sure that the little boxes aren't obscuring the printing on the screen. Maybe you can take care of that, Ashley. I don't know. Okay, the second premise is that drugs are what change the brain in addiction. And there's a lot of reasons to dispute that, especially because we see very similar brain changes in, first of all, in all kinds of other addictions, to gambling, porn, sex, gaming, internet use, and so forth. I mean, really similar changes in the regions and the neuromodulators that get used in those regions, and so forth. It isn't just drugs. In fact, obesity, the last one on the list, has been studied by NIDA, by Nora Volkow, the head of, I believe she's still the head of NIDA, who found similar changes in the orbital frontal cortex in eating disorders as you see in drug misuse or drug addiction problems. So it's not drugs that are causing the change. It's something about addiction that can include drugs and all of these other things. And the third premise is that addiction is chronic. No, it's not. It's not chronic at all. I mean, as I mentioned, I stopped, and most people stop. And a guy named Gene Hyman has actually composed timelines, and very reliable timelines for the time it takes people to stop different substances on average. The median time to stop once you start using addictively, something like 4 years for cocaine, 6 years for cannabis, something like 12 or 13 years for alcohol, and I think 23 or 25 years for tobacco. So tobacco is a bad one. Better not to get started. But there you have it. It's not chronic. So what was that about? Okay, and most people recover from addiction not through treatment. So there's an awful lot of work on growing out of addiction, on spontaneous recovery, whatever you want to call it, maturing out of addiction. People stop using or doing addictive things because it becomes too much trouble, because it becomes too disruptive, too upsetting, too destructive, or just boring. Okay, whereas, yeah, most serious diseases get worse if they're untreated. So, okay, all that stuff. Well, I spent years, giving that talk. I don't want to give it today. It's really just a preamble. And this little billboard kind of says it all. This is one that was, you would see quite a few of these on the side of the road, and this one's in Massachusetts and other places. Addiction is not a choice, it's a disease. Well, that was really the problem, was this polarity between the idea of addiction as a pathology and the idea of addiction as a choice. And that has been talked about a great deal in the last many years. And I'm not going to stop there either. Again, it's another kind of forerunner to what I want to talk about the most. But you see all these happy people. Well, they're happy. They're kind of smiling. They're not really happy, but they're sort of smiling because they can't be blamed. Because if it's a disease, you can't be blamed, right? It's not your fault. So this kind of either or thinking has been a real problem in the scientific community and in the treatment community. People who are told they have a disease actually end up doing not as well as people who are not told they have a disease, because of things like, okay, why is the disease model unhealthy? Because, first of all, the brain disease model tends to obscure environmental causes. I believe that's changing, but I think that's been the problem historically. If you're looking at the brain, you're not looking at what's going on in the room or in the neighborhood or in the culture or the society. And that's a matter of focus. Environmental contributions, well, we know quite a bit about them. Trauma, abuse, neglect, childhood issues, bullying, isolation, all kinds of nasty stuff that goes on in the schoolyard, and more general societal problems like poverty, racism, and unemployment make people miserable, make people anxious and helpless and feel trapped and isolated and alienated. And so if you can't find other ways to feel good, maybe drug use is the answer for you. Maybe for a while, that's actually doing you some good. We don't have that kind of conversation in the halls of addiction treatment centers, but it's a conversation that really needs to be a part of our dialogue. Number two, the disease model reduces empowerment just by its nature. If you say someone's got a disease, then well, like I said, then they really applying effort, trying to find creative and individual ways to change their lives doesn't seem to be the right answer. The right answer, listen to your doctor, take your methadone, do what you're told. So there's issues of empowerment that really get tossed on their head via the disease model of addiction. And the last one I'll mention is that the idea of the disease model was to reduce stigma by taking away blame. It's not your fault, it's a brain problem. Problem is that you take away one form of stigma and you replace it with another, because now you have a mental illness, right? I mean, if it's a disease and if it's in your brain, then it's a mental illness. And we know from decades of work in anti-psychiatry and all kinds of different veins and disciplines that being defined or conceptualizing oneself as a mental patient is not much fun. And it's not really doesn't make it very inviting for someone to want to sit down at a table with you and talk to you and get to know you because you have a mental problem, you have a mental disease, and that's not a good thing. So it's not really helping with the stigma issue as thoroughly as we might like. Okay, so uh, I just had fun with kind of Google Images. I mean, you can make almost any point with images, and it's the most fun part of preparing a talk for me is looking at the pictures and seeing how I can use them. Okay, so for all of these reasons, the climate is starting to change as far as the disease model is concerned. 5 or 6 years ago, addiction is a chronic disease. This is the National Institute of NIDA, the National Institute on Drug Abuse, their website. They have a lot of web pages that are right there in your face telling you what addiction is and how to define it and what to do about it. That was 5 or 6 years ago. Then comes, subject to acerbic criticism in recent years. So there's a lot of argument going on within neuroscience and between neuroscience, psychology, sociology, and other disciplines. And now I looked up recently, I was trying to find something about disease on a NIDA website. I couldn't find it. Couldn't find the word disease very easily. I thought, oh, they've changed the wording. Now they're calling it a disorder. Well, I think that's an improvement. Some of my colleagues on the sort of sociological, social psych, environmental end of things thought that wasn't good enough, but I think it is a step in the right direction. Okay, disorder. Well, it certainly can be seen as disorderly in a lot of social contexts and creating as many problems, or perhaps many more problems than it solves. Okay, so things are changing. Now what? What do we do? If the idea of a brain disease is no longer viable, no longer informative in the same way, does that mean we stop thinking about the brain? A lot of my colleagues who take a more, shall we say, somewhat radical perspective on addiction want to say things like, is addiction even a thing? Or is it just a definition imposed by societal organs on people who are doing something that we don't like? Okay, I mean, what does it mean that people are allowed, alcohol is legal, but heroin's not? Carl Hart has made a lot of that in recent years, talking about really giving voice to the idea that it's nobody else's business what substances, what chemicals I take to nudge my internal chemistry if I'm not hurting anybody. And I think, it's a valid argument in many respects. From the sociological end of the spectrum, psychologists and philosophers and people like that, they're basically saying we don't want to look at the brain because that takes our attention off the things that are most important. As I said, the cultural and environmental issues, historical issues, trauma, abuse, and all the other forms of social oppression that can that people can bump up against in individual lifetimes or as a community or as a subculture. So does that mean we get rid of the brain? Does that mean we stop thinking about the brain? Is it just a false lead? And I think it's a real question. I'm not just making it as, I'm not just directing that argument so that I can shoot it down. I really still wonder, when I do my work with clients who have addiction problems, I'm a clinical psychologist, I'm a registered clinical psychologist in Toronto. I'm not thinking about their brains very much, really very much at all. And when I think I can help them resolve their difficulties, it's very much about what's going on in their mental space, the voices, not out loud voices, but the voices that we all hear in our minds criticizing us, telling us that we're no good, angry, self-denigrating voices, people living with shame, often as a result of trauma or some form of abuse. Very, very common to see addiction following some form of child abuse, whether it's physical, sexual, or emotional. Very common. So I'm not thinking about their brains exactly. But then on the other hand, I'm really aware that their brains are there and that the brains are really what I am ultimately dealing with. I mean, they're dealing with my brain and I'm dealing with their brain. And so it's a real question as to where understanding brain processes can help us in thinking about how addiction works in real life. So yeah, I want to argue that understanding brain change in addiction does help us understand the process. And I want to present a couple of examples that I think demonstrate this kind of this valuable kind of perspective, this joining of perspectives, and see what you think about it. The kinds of things that more generally that I think brain science can help us with is understanding the role of repetition in learning. How is addiction similar and different from other forms of learning? Repetitions involve when you're learning to play the piano, when you're learning to fall in love, when you're learning to be a parent, when you join a religious organization. Repetition is a fundamental aspect of learning, and addiction epitomizes repetition in the sense that, if you're pretty addicted to cocaine, you're not really thinking about whether or not you're going to take cocaine today. You're going to look at cocaine like you do every day. You're going to have a drink at night like you do every night. So repetition and choice and habit are certainly associated in fundamental ways, and maybe looking at the brain can help us understand that. The main problem, the calling card of addiction, is that it's really hard to stop. That's kind of the street level definition. Why is it so hard to stop? Well, maybe looking at the brain can help us understand that. I think actually that's a pretty big one. And people, when they know some of what I've looked at in my writing and my research, they say, well, okay, you can tell me why it's so hard to stop because you understand the brain. And maybe there's something to that. And I guess the big question is whether addiction is a choice or not. One way to address that polarization, is it a choice or is it a compulsion? Maybe it's not a disease, maybe it's just a compulsion. Well, that's pretty bad. Feeling that you have to do a certain thing day after day, night after night, even though you're not really thinking about it and may not want to. Compulsion is not a good thing. So what does looking at the brain tell us about these kinds of big questions? Here is a pretty standard sketch of the main systems that people talk about when they're talking about addiction neuroscience. We have got the striatum, a very old structure within the cortex that is in charge of action and in charge of motivated action, what you're going to do, and giving you the attentional focus, narrowing the attentional focus on the goal, and then getting the drive or urge to do that thing, whether you're biting into a piece of pizza or whether you are calling your dealer to get some heroin. It's that urge, that action, and then the strengthening of desire, which are attributed to the striatum, this organ of action and motivation. Okay, that gets fueled, so to speak, by systems in the midbrain that send dopamine. And we always hear about dopamine when we look up the neuroscience of addiction. Dopamine's a big number. It's the main perp. People actually think that, that drugs have to give you dopamine in order to be addictive. Well, it's not that at all, because, as I was showing you before, the whole addictive process looks the same whether drugs are involved or not. And things like opioids do not directly give you dopamine at all, but there might be something about the seeking or the drive or the commitment or the stuckness that does have to do with the dopamine system. So we're going to keep that in mind as an important part of the brain map. And then regions of the prefrontal cortex. For now, dorsolateral, the upper regions, which are more in charge of executive processes, perspective shift, decision-making, planning, stuff like that. And the ventral portions on the bottom, the southern, sometimes if you're not into these anatomical signposts, it helps just to think of the northern part and the southern part. So the orbital frontal cortex down here, very important in emotional attributions, emotional decision-making, reading, and sending emotional messages. Okay, so what's going on in addiction? Oh yeah, I've got my little tags here. So there's motivated action, the dopamine pump, value attribution, and perspective taking and judgment. The first thing is that there's a balancing act between the striatum and the prefrontal cortex. When the striatum is saying, I want to do this thing, and the prefrontal cortex is saying, let's plan this, let's think about it, let's decide how to do it intelligently so we won't get in too much trouble. So there is a balance going on between planning and delayed error monitoring and all that stuff in the prefrontal cortex, and the drive towards known actions in the striatum. And both of those regions are heavily innervated by dopamine from the midbrain. Dopamine is going not only to the striatum, but to the prefrontal cortex as well, and doing its thing. And what its thing is a very complex question. But what happens in addiction is somehow the balancing act gets changed. And I'm going to get into that a little bit more in a minute. When people get what you might call addicted to substances, they're seeing less of that kind of synchronization or functional correlation between activity in those two structures. And that could be serious. Okay, so what do the data tell us in more detail? First of all, we know that over time, dopamine uptake from the midbrain is sensitized to drug-related cues, whether it's finding half a pill on the bathroom floor, or you're walking by a bar, or seeing your dealer's phone number fly up on your whatever your phone because he's just got a new batch. These drug-related cues get dopamine flowing up to the striatum and the prefrontal cortex. That causes changes that include reduced activation and reduced synaptic density in the prefrontal cortex. So that's what I'm going to focus on. Reduced activation and reduced synaptic density in the prefrontal cortex. What's that all about? Yeah, and as I said, what the prefrontal cortex is doing. Okay, so this is an old study. It's almost 10 years old, but it really shows some of the stuff graphically in a way that I've never seen any improvement on. And what we're seeing here is that people who use alcohol, cocaine, or heroin in an addictive way for 5, 10, 15, 20 years, whatever it is, show that linear, possibly reduction in gray matter volume. Gray matter volume, the amount of synaptic, the amount of material. It's mostly dendrites, it's the extensions that come out of the neurons that allow them to communicate with each other. So there's a reduction in the amount, the weight, the thickness, the capacity of those cell parts in the prefrontal cortex with years of drug use, drug or alcohol use, in very specific areas. And the specific areas, this is what an MRI looks at. Obviously, it focuses in on the area and asks how much change has happened in that area over this period of time, before and after. So this looks like prefrontal cortex or anterior cingulate, which is very much related. Okay, well, that doesn't sound good. Gray matter volume, shrinking in prefrontal cortex looks suspiciously like a brain disease. That stuff is melting away. But there's other ways to look at it. Just down here. Yeah, then the first one is that in normal learning, synapses are underused. Some synapses get used more, some synapses get used less. And when that happens, those synapses are pruned. Pruning means that they are reduced in volume or thickness, or they're weakened, or they disappear entirely. So the reduction of gray matter has an entirely different interpretation. It may not be a pathological process, but a really fundamental process in normal learning. And what that means is simply that the communication among neurons becomes more efficient, becomes more streamlined. Rather than having all these different neurons involved, the pattern of neuronal activation becomes more and more circumscribed, more constrained to a particular route, and that makes things more efficient. And what you do want, above all things, is an efficient brain. You don't want a whole bunch of neurons to be firing. You want a particular pathway that leads you from A to B, from here to later, from the present to state of need or wants to the end state of goal satisfaction. Okay, so this is how the brain changes in general. And I guess to look at it a little more holistically, you can have waves of synaptogenesis, synaptic enhancement when you learn something new, whether it's a piano playing or a drug habit. First you get more synapses growing in certain areas, and then you get pruning of synapses around that network, so to speak. So the network becomes more exclusive, more constrained, more more efficient, more localized, And not everybody knows this, but the infant brain has got about twice as many synapses as you end up with in adulthood. So you actually lose synapses with development more than you gain synapses as the brain becomes more efficient. Okay, so that's a pretty interesting factoid. And I'm going to show you something about that in a minute. It's hard to get an image of synaptic pruning if you haven't thought about it or sensed it or whatever, but it might look something like this. Okay, reduction in the connections among neurons until you get a more efficient direct pathway between one assembly and another within or across brain regions. This is a slide that I showed for years that I stopped showing, but it's such a cool slide. I just have to show it again. And it's not directly related, but what this shows is synaptic change in development in general from the age of 4 to the age of 20. Phil, have you ever seen this?
I have indeed. I used to show it all the time too.
Oh, okay. So yeah, it's great. So watch closely because it's an 8-second video. And what you're going to see is a change in color as what you're seeing is the colors represent the density or thickness of the cortex across all these different regions. And here's the scale, the amount of gray matter or the thickness of the gray matter of the cortex itself changing from, well, you'll see. Okay, I'm going to watch it the first time. Here goes, watch carefully. There you have it. Age 4 to 20 in 8 seconds. And what happens in development is your brain turns blue. That's what happens, right? That's the message here. No, seriously, what's happening is you're seeing a shift from yellow and green to blue from region to region. And that shows a reduction in gray matter amount from of about 50%. So there's an ordinal scale from 0 to well, 100%, whatever, in gray matter density, and you're seeing it go from 0.2 on that scale to 0.1 in that scale to deep blue all over the cortex. But it does it in stages, different regions mature or prune up at different times, and that's what's so interesting. So look again. So I'll stop it right in the middle. Now you're about 7 or 8, 9 years old. The orbital frontal cortex is already fully pruned up. So is the sensory motor strip. What isn't pruned up is this area here, which is still yellow and green. And that area is dorsolateral prefrontal cortex. So, at the beginning of all the, what happened? At the beginning of all this, when you're 4, and this is already pruned up. The orbital frontal cortex and the motor strip are already pruned up. Why? Because 4-year-olds are able to climb trees and kick a ball and do all those cool sensory motor things. They're very good at it, just about as good as anyone. And so these regions have finished maturing. What hasn't finished maturing, and the orbital frontal cortex is involved in emotional communication. If you're 4 years old and you don't know yet whether your mom's mad or whether she's in a good mood, then you're in trouble. So it's really important to have the orbital frontal cortex, shall we say, wired up or as efficient as possible by the time you're in early to middle childhood. But this is the delay, this area responsible for decision-making, planning, and perspective change and all that good stuff. And I should know because I've got my second generation of kids growing up here at my home, and they are now 15-year-old twins. So they're right in the middle of this timeline. And indeed, so here they are at about such and such an age. It's still pruning up here. So they're still learning how to use planning and decision-making, and there's a delay of gratification and things like that. They're not very good at it yet. They say teenagers aren't, they don't think very well. They do a lot of things very well, but in terms of intelligent planning and perspective change and stuff like that, they really haven't got there yet, which is why they're so frustrating and why they why they don't want to talk to us anymore. Okay, but they get there hopefully by the age of, here they are turning 20, and it's now pruning up, and they're ready to go to university and become masters of the universe. There you go. Okay, so a little bit about synaptic pruning, a very important neural process. synaptic pruning following synaptic growth is how the brain changes itself in general. Well, addiction actually epitomizes something fairly important about normal learning. Making the same choice time after time means less activation in networks used to make choices. So the prefrontal cortex of many of those regions are involved in active decision-making and planning, and you're not doing too much active decision-making or planning anymore, then those regions don't have much to keep them busy. And the balance of power back to the striatum then makes sense. You're just not thinking about it anymore. That's a big problem in addiction. You're not thinking about whether, you're just thinking about when, how to get the money and how to, fake it to your parents or your wife or your kids or whatever it is. That does involve some hard work for the prefrontal cortex. Okay, so what I am saying is that addiction epitomizes habit formation, doing the same thing time after time. And what happens in habit formation is that things become automatic by definition, prefrontal cortex becomes less involved, and therefore, in some sense, flexibility and choice really aren't happening as much anymore, whatever the habit may be. So this kind of looking at the brain to understand different kinds of learning, different styles of behavior activation, where can we go with that? We can ask, for example, what parts of the prefrontal cortex get pruned with addiction? That'll be important. The orbital frontal cortex is one of those parts. Well, that's really important because that's how we read and send emotional signals. That's how we do valuation. So if we're losing synapses there a lot, if we're losing flexibility there, that might count for a lot. Yeah, what I'm saying is, what else are these regions used for? And therefore, to help us throw light on what it means if they become less accessible or less activated or less energetic. And then this is kind of a big question when it comes to treatment and change. How quickly or how thoroughly do pruned synapses grow back? If we're losing synaptic volume, synaptic, that's a hard word, synaptic thickness in those regions, can it change back? People ask me this all the time. We understand that addiction involves some kind of wiring or reprogramming of the brain. Can that be undone? That's the question. I usually say, no, it can't be undone, but you can build different synaptic pathways around the areas that have become already kind of used up or committed, okay? And I'm going to go back to this experiment because they have such a beautiful demonstration of that very process. This is Connolly et al. That I showed you before. Gray matter volume going down with years of alcohol, cocaine, and heroin in this region. The dotted line, by the way, is the population baseline for density in that region, for synaptic density in that region. Okay, so what happens when people quit? What happens when people are in, quote, recovery? I don't really like the word recovery because it's a medical word, and I try to avoid medical words, but that's what people call it. Okay, fine. So what I want to suggest is that if normal pruning is the reason for the reduction in synaptic density here, then we should see further synaptic change in recovery. And that is in fact what we do see. Okay, so what these authors found was with these participants, from 20 to 40 to 60 weeks of abstinence corresponds with more or less linear, increase in gray matter volume over those same weeks, increase in gray matter volume over those weeks, which actually crosses the line, passes the line of representing normal synaptic density for those very same regions. In other words, people who've been using drugs or alcohol and stop are showing more than usual synaptic volume in particular regions of prefrontal cortex. Well, what could that mean? Does that mean ex-addicts have big bulging prefrontal cortices that are, way thicker and more have more dense than other people? No, very specific regions though may become used more and therefore grow and increase synaptic volume. because they're learning something else. They're learning how to say no. They're learning how to stop. They're learning how to find different means of emotion regulation. They're learning to pursue different rewards. They're picking up whether it's a hobby, musical instrument, relationships, whatever the recovery work is. They're picking up the 12 steps. If they're in a 12-step program, they're learning lots. When they give up drugs and booze, they're learning something different. And that presumably is a really important aspect of the recovery process. So there's a way in which looking at the brain helps us to think about what goes on in real life. Okay, I'm going to look at one other neural phenomenon associated with addiction that I think also can help us understand the process in more depth. And that is activation within the striatum itself changes over the course of addiction. And this is especially the work of Everett and Robbins. Actually, does this bar with our faces in, does that obscure some of the printing, or is that just on my screen?
Oh, no, you're good. The view is great.
You can see the whole slide, can you?
Yes, yes.
We can, you can't.
Okay, fine, good enough. All right, so what's happening here is that activation is shown mostly when people or rats or other animals are involved in addiction-like behavior acquisition processes. The activation is here in the ventral striatum, which we often call the nucleus accumbens. They're overlapping, not exactly the same. But over weeks and months of this addictive style behavior, activation moves northward to the dorsal striatum, to another region. Well, who cares, right? I mean, who cares whether it's ventral or dorsal? So we have to see how something like this can help us make sense of what's going on out in the real world. But the findings, again, are this shift of activation to different regions of this behavior generating structure. Okay, so what I want to say is that activation in the striatum from ventral to dorsal actually corresponds with changes in behavior. And this is in rodent models and rat models. This goes back to the work of Everett and Robbins. What they're seeing is that the behavior style of the rats changes from impulsive behavior to compulsive behavior, while the striatum activation is shifting from ventral to dorsal. Okay, so how do you measure compulsive behavior in a rat? You know, it's like, okay, what's that all about? Well, rat behavior patterns indeed fall into different categories, just like human behavior patterns do. And the paradigm, it's called punishment-resistant behaviors. When rats are, let's say there's an operant procedure and they learn to get some sucrose solutions, a nice sweet juice from a nearby spout. When they do a certain behavior, they learn that and they start doing it and they say, this is great. One of the behaviors is a nose poke. You poke your nose at this thing, you get a little bit of juice, but then you apply a punishment. So a mild electric shock. And some rats say, okay, that's enough for me. I'm done with this. And other rats, and the rats are literally divided into groups based on different variables. Other rats continue to go for the juice even though they're getting shocked. So that's called punishment-resistant behavior. And you can see the analogy. Clearly, people who have to wash their hands 50 times a day or whatever it is compulsively are doing that despite the punishment, despite the rawness, despite the hassle, despite all the nasty things that happen as a result of the compulsion. It's not fun. There is a punisher involved. So it's a sensible way to think about how to actually put a metric on compulsive behavior, doing something despite the fact that it's not much fun anymore. The parallel with addiction is pretty obvious. That, you know, it might be nice and fun to take various substances for a while. The more you take and the more often and the longer time you take them, the more punishment you get. So then, of course, you start to wonder how much of this is compulsive. And does compulsive mean that there's no longer any choice involved? So that's what I want to ask now. Is that the whole story? Once behavior becomes compulsive, once the dorsal striatum is activated, is that it? No. Because the work by Robbins and his associates shows that, in fact, behavior doesn't just shift to this new region of the striatum, it stays also in the ventral striatum, and the activation is extended upward, extended northward. So that means the behavior maintains a goal-directed, impulsive, reward-driven aspect, even though it's now more resistant to, let's say, unpleasant effects, unpleasant side effects. Well, that's pretty important, because the whole idea that addiction is either a compulsion or a choice starts to fall apart when we recognize that compulsion isn't an all or none game. Compulsion is part of the behavioral activation profile. And take that a bit further and think that all the other stuff going on in the brain doesn't stop because the dorsal striatum gets involved. It doesn't just stop there. Rather, all those other things are still going on. And we know that, in fact, people don't have to take a drug or drink a drink, even if they are alcoholic or addicted. They can put it off for an hour. They can put it off until, until this evening, if they can. They can still choose. So, and I think that speaks to research paradigm called contingency management, in which people like Carl Hartigan and other people will take a population, we'll take a sample of addicts, usually they use psychostimulants. So these are meth addicts, meth or cocaine addicts, and they give them a place to stay for a few weeks. And on every day of that stay, or most of the days of that stay, they give them a choice. If we give you a certain amount of money, would you do without the meth for today? And all you have to do is raise the amount. $5 isn't enough, $10 isn't enough, but if you give me $20, okay, yeah, I could give it a break. And it's not that they could just go out on the street and buy meth, because they don't get the money until the end, okay, until the end of the 3 weeks. So that's not the reason. Rather, they're using their prefrontal cortex, presumably, to make a decision and decide what's best in the big picture. And I think that's pretty good evidence that compulsion isn't the only game in town once addiction is happening. It's part of it. And it's an important part of it. And what I conclude from that is that choices are more difficult when you're addicted, however you define addiction. It's hard to stop. It's hard to change. It's hard to say no. It's just hard, because these brain regions have indeed been wired up. They have indeed, been activated and fallen into patterns that work without your say so, because the brain is indeed a biological organ. This is what my clients ask me, how much of this can I control? Well, some of it, but maybe it takes time, because brains take time to change and to learn. Compulsion makes it harder to choose to say no, but it doesn't make it impossible, not by any means. Okay, so future directions, we'd want to ask, I think, questions like, what's the time frame of this wiring of a brain region that is responsible for compulsive behavior? What's the ratio of activation between, in this case, the dorsal and ventral striatum, the ratio between the impulsive push and the compulsive demand to emit a certain behavior? Compulsion also is, I want you to think of it as broadly as possible. In one sense, compulsive behavior is like Pavlovian conditioning. So there is a direct response to the stimulus that isn't about seeking a reward. Stimulus response, you remember from your undergrad psychology, stimulus response. The behavior is triggered by the stimulus. It's automatic, but again, it's only partly automatic. We want to know, what does the rest of that picture look like in mind and in brain? Okay, so we want to know, what's the time frame? What's the ratio of activation among this and other brain parts? There's no reason why we can't find these things out with some of the cool technology that's available now. How quickly and thoroughly do compulsions develop? And how does this stuckness of the dorsal striatum, this compulsive aspect of behavior generation, overlap with other features of the behavioral repertoire? So sorry, there are a lot of long words in that sentence, but what I mean to say is how much is compulsion or stuckness just a part of life? So we see extremes, for example, in OCD, obviously. But, you know, when you, my favorite example is sometimes when I argue with my wife, I know that it's not going to work. I know that I shouldn't be saying the things that I'm saying. It's just going to make her more mad, but I do it anyway, right? It's pretty much automatic. And even when I think about it, I shouldn't say that. I shouldn't, well, I'm going to say it anyway. She has to hear this. Well, that's a real life example of a kind of behavioral output that is stimulus bound and not very much controlled by other processes, planning and perspective change, for example. Okay, so when we think about treatment, I'm going to stop in a couple of minutes. When we think about treatment, I started at about 2:15 almost, so I'll stop at, that would be 11:15 your time. So I'll stop by, within 5 minutes. Treatment, what about treatment? So I think the first question is, should that be our first question? Should that be our first concern when we're dealing with an addiction problem? Do addicts need to be treated? Well, I already mentioned that most people who have an addiction problem quit without treatment. Treatment is not the best way to quit. In fact, when you shovel somebody into a rehab, the probabilities that go up most distinctly are the probability of suicide. That's one. Okay, suicide becomes much more likely as soon as a rehab is involved. Because first of all, the idea of living without that thing, having it wrenched away from you, is incredibly upsetting and leaves a lot of emptiness and loss behind it. There's all kinds of other issues about treatment. For example, the need to conform and to develop a completely normal behavior pattern without the use of a part of your chemistry set that's been a part of your life for however long. It's a really awkward and perhaps dangerous way to proceed. And by the way, we don't do that with antidepressants or anxiolytic drugs. We don't make people stop suddenly when they're taking antidepressants. We know there's all kinds of harmful sequelae if we do that. Okay, so there's a chemical component of that, but there's also a psychological component. But deeper than that, I think what we need to think about is, why do people use drugs in excessive ways that are hard to control? Why do they let themselves go that far? And this is a question that we all ask deep down. And the first thing you're going to find is that people have problems in their lives. They're struggling with depression and anxiety. And the depression and anxiety are very often a result of trauma or abuse. Okay, so should we be treating the addicts, or should we be turning our attention to, and I know that Phil, that you're, I don't know, I assume that you're interested in these issues. Should we trace it back to family dynamics, family patterns? If we can heal families, then addiction may not be the kind of problem that we think it is. And of course, all the other societal issues, the extra individual issues, whether it's poverty, whether it's racism, whether it's unemployment, all of those things matter a lot. And what it really comes down to, and I talk with these more radical addiction people quite a bit, and the problem is not in the addict. In fact, drug use is a reasonable adaptation to what's going on in their lives much of the time. Now, you can show me pictures of people that are lolling on the sidewalk, with their hands out or sticking needles in their arms on, a main street in San Francisco, and say, are these people actually adapting to their problem? I don't think so, but they are. It's not the best adaptation. It's an adaptation that's got all kinds of nasty side effects or after effects. However, one way or another, they're just trying to make themselves feel better. So you got to ask, what's making them feel bad in the first place? So that's pretty much what I'm saying. I'm going to just show you one more slide that I just thought is just so interesting. This is from the world of concept mapping in the brain. It's not directly related to addiction, but I think it throws light on so many things. So simple conceptual categories: animal, tool, plant, human, all of these things. If you get a subject to think about these things or to use words from these categories, what you will see is the different color regions, the regions of that color will light up all over the brain. This is basically a flattened cortex. Okay, it's taking the cortex and just flattening it out. And I know it looks like a kind of a map of a continent or something, but it's really just the cortex flattened out on the tabletop. And what you see is that even a silly category like plant shows activation all over the place in the OFC and here and here and here, down here and there, and all of these different regions. So you take a concept like cocaine or heroin, which is just so, shall we say, salient to the user, and you're going to show that there's many, many, many different parts of the brain that are involved in thinking, hence feeling about that concept, about cocaine, about my use of cocaine, for example. Why is that important? Because when we think about treatment and we think about how to treat people who have drug problems who want to be treated, the first thing to recognize is that there are so many ways into the system. It's not just one little road. The 12-step, obviously the 12-step, and shall we say, movement over society since 1935, it's been hugely beneficial to some people, and it's hugely not beneficial to many other people. A lot of people have bad stories to tell about 12 steps, like they do about conventional rehabs and so on and so forth. Well, okay, it's not for everybody, and different 12-step groups appeal to different people in different ways. So I'm not sure exactly why I titled the slide this way. When all else fails, there's psychotherapy. I guess what I mean is when someone needs to go to somebody, to a place or a person or a room for treatment, then what's available? You got the conventional treatment modalities, basically pharmaceuticals like methadone, and the 12-step method, which is really based on kind of a religious orientation, although there are many variants of that nowadays. So you got those, and I'm not bad-mouthing this. These are really important ways of treating the system for people whose lives are really a mess and who are facing death by overdose or other incredibly difficult issues and who need help. So yeah, I'm not bad-mouthing that, but there are many alternatives as well. And nowadays, there's this profusion of psychotherapies that really take very different approaches. You probably know of most of these. Cognitive behavioral motivational interviewing ACT is often called for. It's often thought to be well-tailored for addictive problems. Internal family systems is the therapy mode that I use. I like it very much. And it's not a kind of family therapy at all, but it speaks to the internal family, which means all the little people, the voices that we carry around inside our heads, the critic and the angry child and the shamed child and the, this and that. And it's a way of thinking of the self in terms of the parts. Okay. But you got tools that work at the societal level as well that aren't psychotherapy really, that contingency management, for example, what I talked about, community supervision, recovery communities, community approaches to individual problems can be a very good idea. And then you got stuff like EMDR, which simply brings memories forth, different kinds of memories that you can put them on the table consciously, and they've never been available. So you can now work with them in a way that you couldn't before. All I want to say, many different roads to roam here when people do wish for or need treatment for their addictive problems. And that's it. That's pretty much all I want to say about thinking about the brain. And to me, it's still an open question. I don't know how much these kinds of insights depend on or require or benefit from a neural perspective, but some of them do seem to. And we certainly don't want to give up thinking about the organ, which is responsible, which is the substrate of our thought, emotion, feeling, and our personalities and everything else that we do. We don't want to stop thinking about that, even though we might want to stop using the word brain disease. Okay, thank you.
Marc, that was phenomenal, really. Just the breadth and the depth of your thinking on these topics. I'm sure others share my sentiments that it really is transformative in terms of thinking about these very subjects that our center grant focuses on. So first, let me just express my gratitude. And then I think if we can stop the screen sharing I've asked people to either post questions and comments in the chat or to raise their virtual hands. Hopefully you'll be able to see that. If not, I can facilitate the Q&A process.
I'm just going to get a glass of water very quickly.
No worries at all.
Okay.
Ashley, can we, on our end, stop the screen sharing?
Yes, just 1 second.
Great, thank you. And I think we have to can we de-spotlight so that it's not just the three of us, but people can see each other? An advanced feature.
Yep.
So I think we have a question from Camille, and I will allow you to talk, Camille.
Great. I'm sorry if I have any disruptions or background noise here. I always have children and playing in the background. But I have a couple of questions. So you talked a little bit about the social and environmental issues in that that paper by Marcus. Is it Hailing? I can't remember. We've read it recently in Journal Club. And a couple of the things that he mentioned as sort of bolstering the point of like the brain disease model were related to genetic predisposition. And also he talked a little bit about wanting to classify addiction as just the people who experience the chronic and relapsing piece of things. So those are not necessarily related questions, but I was just hoping you could talk a little bit more about what you would say to people who are sort of arguing that because there's some genetic underpinning that means that it's a disease. And then also, wondering about your thoughts related to classifying addiction just as this sort of tip of the iceberg of substance use disorder.
Well, I'll get to the second one first. Tip of the iceberg as far as substance use disorder. I don't have a whole lot of use for DSM categories in my own work and thinking. So even the term addiction is so arguable. It's so, I mean, it just isn't clear what addiction is. And so I think in terms of people's individual problems, and I think, there's always, you want to call it co-occurring problems. Well, even that seems kind of silly because of course they're co-occurring. It's co-occurring with depression and anxiety and feeling shitty and not having the resources to regulate your emotions in the most satisfactory or lasting way. So I don't really mind what you call it, substance use disorder or addiction, either way. As far as the genetic correlates, it's, there's been a fair bit of argument and debate. I think people simplistically say, well, there's a strong genetic component. So, doesn't that mean it's sort of like a disease or that kind of some kind of pathological thing? Well, first of all, when genetics contribute to any kind of pathology, they do it as is in a probabilistic way. It's always in interaction with environmental variables, always, 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 except in very, Huntington's or something. There's very few syndromes that are purely genetic, very few. Even schizophrenia, strong genetic component, totally depends on environmental triggers. So with addiction, you have what behavioral geneticists do, as far as I understand it, is they load up the degree to which identical twins living apart share a particular outcome. And they say, okay, we'll add that to the pile of what's genetic. And you add a bunch of stuff to the pile and you get up to whatever it is, 50 or 60% or something like that. However, the pile is composed of things that are radically different. In other words, there's a genetic predisposition toward being highly social, risk-taking, extroverted type person. That's got a genetic loading, yeah. So people who are like that are more likely to have an addictive outcome because they're more likely to try drugs and play around, and mess around, take chances. Okay, fine, risk takers. But also people who are more introverted, people who withdraw from risk and social challenges and stuff like that, are also more likely to become addicted. So what are you gonna, you add those things together because they both speak to a genetic loading, and yet they are radically different precursors, radically different predictors. Of course, they're all probabilistic. The fact that it's so many different things that predict to addiction tells us that it's not genetic in the way that we'd like to think. It's not, there's no addictive gene or addictive personality style per se. There just isn't. You can't find it. And when people say, well, my father was an alcoholic and his father was an alcoholic and all that stuff, yeah, okay, so maybe they were also risk takers, and some of those personality trait characteristics that have a genetic loading do indeed predict a higher likelihood of becoming addicted, yes. However, what your father and grandfather also shared were models of caretaking, parenting styles, right? And I mean, maybe shouting at the kids and shutting them up and, you know, ignoring them was part of that household, that family as well. Well, that also predicts to addiction. So I just don't find the genetic argument very interesting for that reason.
Thank you so much.
Welcome.
Other questions, other hands?
I'd like to hear your thoughts about this issue. I mean, I know that I opened up a lot of doors here, probably opened more than I closed. That was kind of my purpose. But so I would like to hear how some of these ideas strike you. So maybe some of them are a bit off the wall. I'm not sure how you would feel about them.
I would love to hear others' reflections as well. I'm chomping at the bit to put a couple of things on the table, so maybe others could be preparing their hands and so forth. But number one, I've heard some folks that do eating disorders treatment talk about, with adolescents, talk about how explaining the neurobiology of the essentially addictive process in eating disorders can be a really powerful tool for sort of providing a working model to the client about why there's so much dysphoria, why the restrictive behaviors are self-perpetuating, what some of the underlying effects of malnutrition are on neurotransmitter systems and so forth. In your treatment work, do you find these tools to be useful? Do you use any of the concepts that you were explaining to us as an audience in addiction work? And if so, as a therapist, are there contexts in which it's more or less indicated to do so that you found?
So it sounds like you're talking about anorexia, right? Restrictive
Yes.
patterns. So, I mean, I think you're talking about a very specific interaction between the physiological outcomes of a behavior style of living with other physiological processes in the brain or in the nervous system. So I don't know how does it help? How would it help? I mean, with alcohol, for example, you can talk about Korsakoff's, which is a very serious disorder, but it has to do, it's actual brain damage, which is caused by vitamin deficiency in people who drink a lot. I think there's an interaction between the alcohol and the dietary, the inadequate diet. So people will ask about things like that, about physical processes, because they can put their, you can put your finger on it, or maybe not quite, you can't quite put your finger on it, but you can think about it in concrete terms. Oh, well, okay, so that leads to that, and that causes that. And I think that the problem is that some of that avoids the real psychological stuff that's going on here. And to me, the psychological stuff mediates everything. It's the wanting and the fearing and the caring and the shaming. That's what pushes you away away from or towards the food or the drug or whatever it is. And the physiological correlates are, to me, somewhat more peripheral. So I, use them if you can, if it's going to help people think about it. But it's not a direct approach to me.
So it's sort of a mediational path, but not the direct line. And as a result, in most instances, it's not getting at what's going to.
I think it's storytelling, but there's nothing wrong with storytelling. And in therapy, we do storytelling anyway. Storytelling galore. We, developed huge metaphorical systems, especially in psychodynamic approaches and stuff like that. But And that's great if they work, if anything you can do to hook a person's meaning system to the problem at hand, anything you can do to actually allow them an inroad to thinking about the problem is helpful. I certainly wouldn't knock it.
Yeah, that's really helpful and quite interesting.
Yeah. Okay.
Yeah. Okay, anybody else with a question or comment?
Yes, we have a question from Shannon Peak.
Thanks. Thanks, Dr. Lewis. That was really, really inspiring. Like, I really love the topic, the mixture of brain development and addiction treatment. We work with a lot of parents of young children, and their parents sometimes some of those parents are working on behavior change for themselves for substance use or other behaviors. Mm-hmm. And sometimes we find that they have existing beliefs or concerns, I'll say concerns, that they might pass those tendencies on to their children, and even while they're working on their own challenges. I'm wondering if you've found any indications of factors in some adults that predict shorter time frame to behavior change, something that might translate to a skill that parents could begin working on for their children.
So
Does that make sense? I don't know if that makes sense.
I think so. Like changing the way they talk or think about addiction or drug use or something like that as a mediator of their children's being able to, overcome their difficulties.
Yeah, partly that, but mainly I'm thinking, are there anything that predicts who can shorten that timeline to behavior change? You mentioned some of timeline to behavior change for different substances.
Yeah.
And I'm trying to think about whether there are some things that are predictive for people who can do that faster, that represent a kind of a skill, like a flexibility of change.
Right. Well, that's a good point. I think you're right. And is it Dweck? Was it Carol Dweck? Like, I'm so far removed and away from academic psychology these days, but I think she who distinguished two very, very different learning styles. One is based on the novelty and flexibility, and the other is based on the idea that people have certain built-in skills or built-in levels of intelligence or competencies. What's it called? Competency versus
mindsets, I think, is a term she's used.
Okay, so that, like, people get so rigid about certain emotional issues. Emotional issues are the issues around which we get most rigid, right? I mean, the most obvious big example lately is COVID, and the one before that was Trump, as far as I can see. When things are emotionally compelling, emotionally moving, then that's where the divisions between different styles of thinking become the most apparent, and people become most rigid on one hand, or retain some flexibility on the other hand. So with respect to thinking about addiction, it's a very emotional issue when your kid is involved taking drugs that are that are destructive or unhealthy for all kinds of reasons. Of course, parents are alarmed and scared and frightened and often angry. So can they retain enough flexibility to rethink what their kid is going through, rather than, the classic historical, drugs are bad, you better stop or else. How could you come home in that state? I mean, like, there's such, shall we say, built-in or highly practiced styles of thinking about drugs as bad and drug-induced states as destructive, disrespectful, whatever it is. And parents very often fall into that pattern of thinking, and it's not terribly helpful. When I'm counseling parents whose kids have addictive problems, I see if there's a way in which they can leave the door open in dialogue or conceptualization, but I also help them to recognize that there's a point past which you don't want to go. You don't want them coming home, and smoking meth, at 3 a.m. That's really not allowed. Okay, you can't do that. And well, then what happens? What if they're on meth? Well, they might be sleeping in the backyard that night. So there are ways and times that strictness is necessary for families to just protect themselves against chaos, right? But generally speaking, flexibility is really important for being able to talk to kids and connect with kids around drug use.
Great, thank you.
Yeah, sure. And, I'll tell you, as in my work as a psychotherapist, a psychologist doing psychotherapy with people with addiction issues, the most powerful thing I can usually say is, I've been there, I know what it's like. And they say, I've seen 5 therapists in the last 5 years and nobody has said that. And it makes a big difference to me. I'm so glad that you have had a drug problem. Why does that matter? Why should it matter? I don't know the answer to that, but I think it's because I can sort of travel those pathways and think about the extremes and craziness and conflicts that they might be undergoing. I can think about it with them rather than setting down a moral, framework for basically judging them and trying to coerce them to change.
Great, thank you.
Ashley, anybody else in the queue?
I do not see anybody else with a raised hand.
Okay, well, I'll get to ask another question then myself. So, Marc, one of the things around the populations that this group is focused on is the extent to which the parenting processes that we, I think, tend to see as fairly hardwired into our DNA, like that people have motivation to both from a wanting and liking kind of a perspective, engage with young children, especially with young children. Maybe parenting adolescents is a whole different, kettle of fish, but that affiliative, bonding and attachment and all of the things that our field talks about are really sort of part of the evolutionary conservation of all species, but especially, us as humans.
Mm-hmm.
And what we see with addiction is that those processes can kind of get hijacked or co-opted, where just from sort of more of a clinical or phenomenological perspective, we see parents become less, they perceive their children less as sources of pleasure and more as sources of stress.
Yes.
There's less experience of positive reinforcement, but addiction also shifts the whole orientation away from positive reinforcement to negative. And so I'm interested in sort of your free associations here around, as you see therapeutic processes begin to unfold.
Mm-hmm.
And if you're thinking about this in terms of, the strengthening of top-down processing from a more, neuroscience perspective, or from just a recovery perspective,
Mm-hmm.
how do you conceive of these things? Do you see them going, are you strengthening, or is it just strengthening top-down? Like the contingency management approaches very much sort of, I think, artificially impose some of those conditions. To a certain extent, some of the strategies that this group uses, a variety of different interventions, are trying to leverage kind of the naturalistic contingencies involved in having a young child in your life to create or to sort of make more salient some of those same kinds of processes that I think end up getting pushed aside in the context of addiction. I don't know that this is a question exactly, but it's sort of like, do you see the presence of a young child in somebody's life as something that can be leveraged as part of the recovery process? Or again, is it just baggage along the way? Is it like it's too indirect, or it's circumstantial to addictions, but the trauma and the pain that may be kind of driving this are sort of less relevant?
I think that's a really interesting approach, actually. Really interesting. like in the work that I do based on the internal family systems model, IFS model, you get right to the strong emotional issues that continue to drive the drug use, for example. And shame is a really big one. Shame, rejection, sense of loss, fear of loss, fear of being kind of expelled from the family. Well, partly because of stuff that probably happened much earlier than when kids started using drugs, from early childhood even, from when parents were not accessible or available for whatever reasons. If there was abuse involved, for sure. Then along comes adolescence, and kids start to experiment with drugs. Parents become more angry and more rejecting of it because they're confused and lost. They don't know what to do. Kid is experiencing even more shame and anxiety and rejection. What the parts of the person that are absorbing these feelings really don't know what to do about them. They're childish parts. When you feel overwhelmed with shame, you just don't know what to do. You try to, pull yourself up and look better and act better and promise never to do it again. And none of that works, just doesn't, right? So what do you need then? You basically need what went missing all along. You need comfort, you need to be included, and you need to have a sense of being embraced psychologically. What I think what they're now calling belonging is one part of that. Isabel uses that word in just about every conversation now because it's sort of a present day, I think, catchphrase for something really important about human interaction. And so that's often what people in addiction need. And Johann Hari made a really valid and exquisitely evocative point about that in his book, Chasing the Scream. He ended up, and in his TED talk, what he puts into one sentence, the opposite of addiction is, what did he say? The opposite of addiction is not abstinence, it's belonging. Okay. And yeah, really good point, because it's not about the substance. It's not about the thing itself. It's about the needs. It's about the feeling alone and lost. Well, I won't keep flapping my lips about this. You know what I'm talking about. I think absolutely, if parents can be more present and more involved and can actually in some way hold out love and acceptance despite the challenges, it can be really powerful and really direct.
Yeah, I think that's very well said. It's interesting because a lot of the approaches that we've been working on involve using video. This gets back to the first thing we were just talking about at the beginning of your visit, Mark, which is microsocial kinds of interactions. When we can extract from streams of video instances where there's positive connection and interaction and make it sufficiently salient to the parent to actually identify that it's happening. It's a bit of a game changer. And it's sort of, you could say that from your perspective that it short circuits the shame and guilt and all the other things and self-doubt and, like all of the internal voices around you're a bad person, you're a bad parent, you don't know how. It's like, here it is, and it's actually there. It's there. You're doing it, and there is positive reinforcement. It may be like a tiny little spark of it instead of a giant flame, but it's there. And I think it's really been transformative for us as a tool, as practitioners as well, to experience that with others is really sort of a game changer around the hopelessness of these sort of dual diagnosis traumatized multi-generational stories that are really hard to work with.
I totally agree, Phil. I think it's absolutely, I couldn't agree more. It's a really important, somewhat radical approach. I think it would hold tons of promise. If you can do that, if you can highlight ways of connecting that can reduce shame, and if the parent can perceive, oh, you're actually, I'm patting you and you're actually feeling soothed, patting in some, whatever, some way, not necessarily physically, but I can still do that for you. You still accept that for me. You want that for me. I thought you wanted to shut me out. I thought you just wanted that from your drugs. No, actually, I want it from you. And short circuit is the right word, yeah, because you got all the internal voices that are reinforcing the shame. It's just accumulating down there in that inner child. The only way to short circuit an inner voice is to go back to the parental voice that the inner voice was modeling from the get-go.
Mm.
Right? The shaming inner voice obviously is modeled from a parent, a scolding parent. Where else would you get it? So if you can take that over and say, well, no, I actually do care about you. I actually do love you. I mean, that's really big. That's big.
Very profound. Okay, we are now at 1 minute to the end. And so what I'm going to do is Dave DeGarmo, another product of Oregon Social Learning Center around the same time that a number of the rest of us has a question. I'm going to just read it to you, but don't feel, I think we won't have time for your response, but Dave can reach out to you separately about it. And then I just want to thank you. So first, Dave's question: to the neuroscientists, for addiction as a disease argument, are brain mass measures and brain activity measures reproducible enough or codifiable enough to clinically indicate addiction as a measurable disease? Or would you argue it is more the case that neuroimaging data are more markers for behaviors and processes, as you were arguing in your talk? So I think it's a great question to leave us all with. As always, Dave, super thoughtful. Marc, thank you so much. I personally can say I've really valued your thinking. Hope that we can continue to engage around this. And I'll just thank you on behalf of our center and all the others who've tuned in for this. It was really great. So thanks so much.
Thanks, Phil. That's really nice to hear. I would like to continue chatting with you as well.
Right.
And sharing perspective. And I just want to say, can I sneak in one last comment?
Go for it.
You're going to Stanford and you say you're on a NIDA funded grant. And I just want to say that I have sort of taken NIDA as, the crosshairs of my arguments, sometimes arguing against their support for the disease model, but it's not so black and white. And Nora Volkow has been much more, in the last few years especially, recognizing the power of environmental impacts. She recognizes it, she knows it, she's got it, and she's paying more and more attention to it from a research funding perspective. So that's good. You can get a good home there. And that kind of funding, it's not just, I don't want to leave the impression that they're the bad guys. And
No, that did not come across at all, and totally agree with the perspective. So thank you. Thanks so much, and to be continued.
Okay, great.
Great.
See you later. Bye-bye.